vessels are like this, and when you squat, you bend them. When they are bent in this way, you will create an angle. Yes? This angle will allow less flow of the blood distally. If you have less flow of the blood distally, the pressure here inside of the aorta will go up. There will be more pressure. The more pressure inside of the aorta will lead to creation of more afterload against the heart. That will lead to the blood going back to your brain. Exactly. It's kind of like regurg, but yeah, it's like a blockage. It's like a blockage, distal blockage of your legs, leading to more blood moving upward, not to your legs. You know? So more blood is going to your brain better than your legs, so you do not lose consciousness. Okay? So they teach them to do so, and please notice this pilot has stuff around his legs. Can you see this black stuff, black straps around his legs? These black straps are to increase his, he can actually pull them, and when he pulls them, they stretch his legs so much, so his afterload will increase. And when his afterload increases, more blood will go to his brain. So when he's going to do a maneuver of ascending, he will not lose consciousness. I'm really sorry guys, but it came on the exam, that's why I'm explaining it. They literally told about a pilot going on the air, and why he did not. They bring like 10 pilots, and 5 of them, they gave them some devices on their legs, and they did not lose consciousness, and the other 5 pilots lost consciousness. Okay, you did not get it. Okay, let me re-explain one last time. So, okay guys, let's make it simple. If you have a water hose, okay? If this water hose, you block it. If you block this water hose, what will happen to the pressure in this area? The resistance and the pressure in this area is going to increase. Good. If you have the same water hose and it's open and it releases water, and it keeps releasing water, you do not block it, but what you do, you just bend it on itself. Like you just take it and bend it like this, okay? You create an angle in it, something like this. What will happen to the pressure in this area? It will also increase, yeah? If the pump is here. Yeah? It will increase. Good. So the pressure in this area increase. So what you are doing in case of squatting, you are increasing the squatting. Okay. What are you doing during squatting? That you are bending the arteries inside of your legs. Okay, look here. You are bending the arteries. Okay. And when you are bending the arteries, what will happen to your afterload? Yes, your afterload will be increased. So during squatting, the afterload will be increased. And if the afterload will be increased, what will happen to the amount of the blood inside of the left ventricle? If you increase the amount of afterload, there will be more resistance against the heart, yes? So if there is more resistance against the heart, it will be like something like this. So this is the aorta, and this is the left ventricle. There is more resistance going backward. So the left ventricle will not be able to push out. If he cannot push out the volume of blood inside of the left ventricle, what will happen to it, guys? Increase or decreased? Yes, it's increased. Of course it's increased because the afterload has been increased. Afterload is the resistance against the left ventricle. So if the resistance against the left ventricle has increased, the left ventricle will not be able to push blood outside of the left ventricle, which lead to more blood being inside of it. And if there is more blood inside of the left ventricle, what will happen to the murmur of MVP, mitral valve prolapse? Become better or worse? Better. Okay, good. So guys, if you did not get it, I will send a couple of videos after the class explaining it even further with like some graphs, and I will send some graphs about it. In addition, I will send you a documentary, a full documentary, and that will explain for you. Okay. So the next thing, except squatting, so that increase the preload and increase the afterload. So MVB and HOCM, what will happen to both of them? Well, we are increasing the preload, we are increasing the afterload, so you have more blood inside of your left ventricle, so both of them will become better. MVB and HOCM will become better. All other murmurs will become worse. Okay, in the handy grip, when you grip your hand, okay guys, you are doing the same thing. You are bending your vessel inside of your hand when you are gripping your hand really hard, okay? Handy grip. Handy grip is like making a fist, like you are going to punch somebody, okay? Kind of something like this, but you can just do it without the device. Like you can just grab your hand really strong, like make a fist. Yeah, something like this, guys. Something like this. So when you do this, you are bending your hand, so the afterload is also increasing. When the afterload is also increasing, that reverse flow across the aortic valve, which increases the left ventricular volume. Remember guys, when we said that we have here the left atrium, left ventricle, and we have an aorta, okay? So if you have more, if you have the following, if you do the handy grip, what happens to the afterload if you do the handy grip? It increases. So what will happen to the amount of blood going out of the from the heart? Will there be more blood going out of the heart or less? More or less? Less. Yes, decreased, less. Okay, so in handy grip, HOCM and MVB will be better or worse? Remember, they become better if you put more blood. They become better. Okay, good. Good. You are starting to get it, guys. Okay, so here, murmur that increase with maneuvers are the following, with the handy grip. They need to be something that can be reversible, because, look guys, it need to be something that the valve can basically is insufficient and is moving blood backward. If a valve is moving blood backward, we call that regurgitation, okay? So it can be aortic regurgitation or mitral regurgitation, or it can be actually a VSD. So let's imagine what is happening. In case of mitral and the tricuspid regurgitation, I increase the afterload, yeah? More afterload. So more blood will be passing through this, and more blood will be going here. Okay, why it's not affecting the stenotic valve too much? The reason that it's not affecting the stenotic valve too much, remember guys, the problem in a stenotic valve is that it does not open. Well, it's not opening to the normal contraction of the heart, it will not open to the increase in the afterload. Get it? So it will be only with regurgitation murmur, the handy grip, because it only affects the afterload. It does not affect the preload. Only murmur that affects the preload affect both the regurgitation and the stenotic murmur. Also, they write for you here, guys, that murmur that decrease with maneuver, the handy grip, if you increase the afterload, you just told me, you have more handy grip, you have more left ventricular volume, so HOCM will be better. Also, in case of aortic stenosis, the sound will become better. Why? Guys, in aortic stenosis, the sound was, tell me please, was it crescendo, decrescendo, or was it holosystolic murmur? Crescendo, decrescendo. Yes, it was like this, this. And why was that? Because he had to push through this tight orifice until he reached the other side. So imagine with me like this. If you had to push through this tight orifice, so it was like so that's the crescendo decrescendo. So now imagine with me, guys. Now he used to push from like a great gradient. Maybe you remember, like before he opens, he had to have this pressure volume loop, something that looked like this, yeah? It reached like a blood pressure of 150 of the left ventricle to be able to push that stenotic valve. Yes? So the pressure here is 150, while in the aorta during diastole it was 80. So you can see the transvalvular gradient. It's really huge. It's like how much? It's like 70, the gradient between the two. So the sound will be like okay, let's imagine that we increase the afterload. The aortic pressure will go up to 130, for example, after the hand grip. So the gradient has reduced. So you will hear the sound much more fainter. It will become like okay, so the sound becomes much better if you increase the afterload significantly. I hope it made sense. So yeah, they write aortic stenosis. There is decrease in the transaortic valve pressure gradient. So yeah, that I hope it made sense. Last thing is inspiration and expiration. Guys, you know this already. We said it a million times. Increase in venous return to the right heart during inspiration, and a decrease in the venous return in the left heart during inspiration. Expiration, it's the left, it's vice versa. Yeah. So inspiration, more blood to the right heart. Expiration, more blood to the left heart. So most right-sided heart murmur increase on inspiration. And during inspiration, the left one goes down, and during expiration, the left one goes up. Okay, guys, it might took a little bit of a time, but if you understand this will be super easy. So yeah, that was investment of our time. Okay guys, let's take 10 minutes break and continue after the break. Today we have a long session. Welcome back, guys. So, now we are going to continue to speak about heart murmurs. So, guys, first of all, keep in mind that this topic is not easy. This topic, like of today in general, is not easy at all, especially the maneuvers. It tends to be one of the most difficult topics for the students, and yeah, you are supposed to know at least like 50% of it today, but by the time it will keep repeating. So I hope like until the end of our course all of you guys will master it, but at least from today's session I want each one of you to grab 50% of it. So let's continue. Now we have heart murmurs. We have systolic heart murmur and diastolic heart murmur. Okay, so the systolic heart murmur, we always said we draw this thing S1 S2, sorry, S1 here, S2 here. Between S1 and S2 is systole. Between S2 and S1 it is diastole. The only murmur you had to memorize was mitral stenosis, and according to this you can get tricuspid stenosis because they are both AV valves, atrioventricular valves, and the other two valves we did not mention were pulmonic and aortic, which will be regurgitant valves, and these all will be diastolic murmurs. The systolic murmurs include the opposite. So mitral, here is stenosis, so here will be regurg. Tricuspid, here is stenosis, here will be regurg. And here pulmonic, here is regurgitation, so here will be stenosis. And aortic, here was regurgitation, so here it will be stenosis. Okay, so let's take a look here. They write the heart murmurs. We have aortic stenosis, mitral tricuspid regurg, and mitral valve prolapse. So let's take a look at it. We have first of all a crescendo decrescendo systolic ejection murmur and a soft S2. So what is this? So the crescendo decrescendo murmur, it's a murmur that goes up and down. Why it goes up and down? Because guys, it's pushing against a stiffened valve. So initially it's really difficult to open that valve, then really difficult, then like so really difficult to open it. The moment it opens, awesome, then it starts closing again. That's why it's crescendo decrescendo. So crescendo decrescendo murmur, it's a systolic ejection murmur and a soft S2. So the S2, if you remember guys, the S2 was due to the closure of which two valves? Let's see if you know, guys. S2 is due to closure of which two valves? Aortic and pulmonic, correct. So yeah, it's a closing and it's soft because like for the stenotic valve is almost closed already, so it will not make that lot of a sound, you know. Ejection click may be present. What is that? Like during the it comes something like this, like the k. In the ending it's kind of the click. When you listen to the sound, a lot of people do not even notice that there is an S1. It disappears. Why it disappears? It's inside of the decrescendo, so it goes something like this. This is how the sound starts. So crescendo, decrescendo, and a click. Okay? So yeah, left ventricle will have more than the aortic pressure during systole, which makes sense, guys, because the valve will be stenotic. The pressure will be more in the left ventricle than the aorta. It will be loudest heard at the heart base. So keep in mind that the heart located in your chest like this. So we consider this area to be your cardiac apex, and we consider this area to be your cardiac base. So 1 is apex, 2 is base. So it's best heard at the cardiac base, aortic stenosis, this area. And they write for us here that loudest at the heart base and radiates to the carotid. Pulsus parvus et tardus. Guys, pulsus parvus et tardus, it means pulses are weak with delayed peak. What does it mean? A lot of students don't get it. They think it's some physiological thing or some test you have to do. No, 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 guys. It's a physical maneuver. You can do it with your hands. How can you do it with your hands? You take your right hand, put it on the sternum of the patient, okay? And then you put your finger between his ribs. You feel the maximal impulse with your finger, yeah? When you feel the maximum point of maximal impulse with your finger, you center your finger on it, okay? And you are feeling the heart beating, beating, beating. At the same time, with your left hand, put your hand on his carotid. So your right hand is on his apex, and your left hand is it's on the carotid. The pulses are weak with a delayed peak. It means that when you feel the carotid pulse, it will be actually weak. It will not be that strong. But with delayed peak, it means that you normally should feel the point of maximal impulse beating and the carotid beating at the exact same time. But in case of aortic stenosis, you will feel the apical beating, but the carotid beating will be delayed. Okay, so the peak in the carotid will be much delayed than the one you feel with your right hand. So right hand on the apex, left hand on the carotid. Right hand feels the first contraction from the heart. It feels like the beating. But the left hand, there is a period of time between the right hand feeling and the left hand feeling. If this delay happen, we call that pulsus parvus et tardus, which means the pulse is short. Parvus in Latin means short. Tardus means delayed. Okay, it can lead to SAD. What is SAD? Syncope, angina, and dyspnea. Syncope, angina, and dyspnea. I have a question, guys. Which one of these is the most dangerous? Is it syncope, angina, or dyspnea? Which one has the worst prognosis for the patient? What do you think? Actually, it's syncope. You are correct, guys. If you forget which one, it's super easy. You know this SAD mnemonic? Do it backward. So this dyspnea only, it's like not horrible prognosis. Angina, it's kind of horrible. Syncope is the worst prognosis. Okay, so it's the opposite of SAD. Okay, so it can lead to syncope, angina, and dyspnea. How come? How come it can lead to dyspnea? How come it can lead to angina? And how come it can lead to syncope? Well, dyspnea makes sense. You have heart failure, like you are not getting the blood out from the left ventricle. But the angina, why patient get angina? Anybody has any idea? So less blood flow to the yes, if you remember, guys, the coronary artery used to rise directly over the what? If we write if this is the valve, the coronary artery used to be directly here. Yeah? Initially, during aortic stenosis, initially only, there will be more perfusion because there is increase in the diastole. But eventually, this guy will be stenotic, okay? And this stenotic will lead to calcification of this valve, yeah? And also, other than that, the aortic valve, since it is located immediately inferior to the coronary artery, it will be starting to compress this coronary artery eventually, because initially we said there is more perfusion, but eventually the compression of the coronary artery will lead to them to be what? Get angina, and if you occlude them, you can get syncope and even death. Yeah? So that's why the progression of the symptoms angina, syncope, death. Yeah? So it was dyspnea is one of the bad signs. Worst will be angina because you are starting to block the carotid. And syncope, it's already like progressed state and the death is pretty soon. Guys, it's a step 2 kind of concept, but if someone has syncope, death occurs within a year. Okay, so death occurs within a year if he has syncope with aortic stenosis. It's most commonly due to age-related calcification in an older patient, if he is more than 60. But if the patient was young, like he was 40, and you can hear a crescendo decrescendo murmur on his aortic area, which is like an aortic stenosis, how come a young man, or a young lady can have this crescendo decrescendo murmur, can have an aortic stenosis when she's still young? So she has an early onset calcification. Why? Because she has a bicuspid aortic valve. Which disease, which syndrome can lead to bicuspid aortic valve? Exactly, guys. It's Marfan Syndrome. Excellent. So if you take a look here, normally you have 3 leaflets, okay? But if you have only one, that makes you like the bicuspid aortic valve. That's like, here you can see how many leaflets are in this picture, guys. All of you got it right. It's 2, not 3. Guys, it's not separated at this area. It's 2. So this is 1 and this is 1. There is a raphe here. It's connecting 2 of them. This is a bicuspid aortic valve. Don't be tricked. It has so many shapes, guys. So see this one? This is a bicuspid aortic valve. There is a raphe. Okay. I'm telling you, don't get it tricked with it, because I personally used to get it tricked. Sometimes it looks like this, and it looks like it has 3 cusps, while in reality it has only 2. So yeah, keep that in mind. Okay. You said it's according to Marfan syndrome. What is Marfan syndrome? Is it a trisomy, monosomy, polysomy? What is it? Well, Marfan's... Okay, good. What about... Guys, I believe you did a little mistake, and I kept going with you. Like the bicuspid aortic valve is not mostly in Marfan syndrome. That was mitral valve prolapse. The one that is really common in bicuspid aortic valve is Turner syndrome. But because I was really excited about the answer, everybody was answering the same. I got this availability bias, we call it. Yeah, so actually it's Turner syndrome, which is a monosomy XO. Yes, guys, it's an XO monosomy. Yeah. Okay. So if they give you a young lady that has an aortic stenosis, you think about Turner, okay? Why? Because she has a bicuspid aortic valve. And why is she's developing the aortic stenosis now? Because it's becoming calcified. And why it becomes calcified faster? Because it can undergo the wear and tear damage much more faster than normal valve. Okay? So in case of Turner, we have 2 diseases actually, not 1. The first one is a bicuspid aortic valve, and the second one is a coarctation of the aorta. This is the relationship with the cardiovascular system. Keep in mind that they also can have a horseshoe kidney, which is super important to know for the USMLEs. While in case of Marfan syndrome, they love to put, not bicuspid, I was wrong, maybe. Someone wrote it and I just was following it. It was MVB, and also one more thing, which is aortic dissection. Okay, guys, these are the 2 that you must know about. And the aortic dissection, you must know why it occurs. The aortic dissection, it occurs due to cystic medial degradation. Okay? Of course, I can repeat. So, in case of where is as with Turner? Okay, let me repeat what I just said. In case of Turner syndrome, there is 2 diseases that you can have. The first one, cardiovascular disease. The first one is coarctation of the aorta. The second one is what? It's the one we just spoke about, which is bicuspid aortic valve. Yeah, bicuspid aortic valve and coarctation of the aorta are both due to Turner syndrome. Turner syndrome is a monosomy in a person that looks like a lady. She has a phenotype of a lady. And if we speak about Marfan syndrome can have aortic dissection, and also it can have mitral valve prolapse. Okay, mitral valve prolapse and aortic dissection. So if we speak about the MVB, it's due to myxomatous degeneration. While if we speak about aortic dissection, it's due to cystic medial necrosis or degeneration, also you can say. It's in first aid. You can find it in the biochemistry chapter. You can come here, go there, really quick. Yes, so you can see here they write in first aid you have Marfan syndrome, you have cystic medial necrosis of the aorta. Okay, guys? Yep. So you can see it here. Okay, guys. So let's go back to our CVS. So in CVS here they mention one more thing. They mention for us, so except of aortic stenosis, keep in mind this graph we spoke about. In case of aortic stenosis, we said that it's a problem with the valve to open. Yes, guys? So if the valve is not opening, yeah, if it's a problem with the valve opening, the valve will not be opening. If it cannot open, what will happen to the pressure in the left ventricle? It will go above normal, yeah? So, yeah, see, it's 150 here. It's 150, so much, 150. Yeah, so this is a sign because of this is the left ventricle in green, it's 150. This tells you that this is aortic stenosis basically. And you can see the gradient between the left ventricle and the aorta has been changed dramatically. Okay, so that was aortic stenosis. Let's speak now about mitral and the tricuspid regurg. Guys, these are the Systolic murmur I kept telling you about. So they are a high-pitched blowing murmur. Blowing murmur is the same as telling you Systolic murmur. So you have the mitral one and the tricuspid. The mitral will be loudest at the apex. The apex of the heart, please remember, it's located 2.5 centimeter right to the midclavicular line. Not at the midclavicular line. 2.5 centimeter right to the midclavicular line. So the mitral one will be loudest at the apex and it will radiate to the axilla. It will go to your armpit basically. So I used to have a problem to remember like mitral valve regurgitation. That's like radiate to the axilla. And if you speak about mitral valve prolapse, it does not radiate, you know. So I told myself like the follows: regurg radiate, regurg radiate, mitral regurg radiate, R with R, regurg and radiate. So mitral loudest at the apex and radiate towards the axilla. Mitral regurg is often due to ischemic heart disease, post-MI. So yeah, after the infarction, you can get mitral regurgitation. Due to dysfunction of which muscle? Can someone tell me? Why MI can give you mitral regurgitation? Yeah, due to dysfunction of the papillary muscle. Okay, excellent job, guys. So, yeah, rupture of the papillary muscle. Okay, also, at the mitral area, you can have like the following. Mitral regurgitation can occur as a complication of the MVB. So MVB can be the primary pathology, and that leads to the MVB. And lastly, left ventricle dilatation can lead to mitral regurgitation. I have a question for you guys. In left ventricular dilatation, is it a valvular murmur or is it an annular murmur? Excellent. It's an annular dilatation which leads to the creation of the murmur. It's not a dysfunction of the valve itself. It's just the annulus around it is becoming bigger. I hope it makes sense. So here we have the next thing they write, tricuspid. It's loudest at the tricuspid area, which is located at the left lower sternal border. They will not tell you this, of course. They will just tell you left sternal border, and you have to do the maneuvers to make sure which one it is. Tricuspid regurg, it's commonly caused by right ventricular dilatation. Yeah? Because, again, tricuspid regurg, right ventricular dilatation. So tell me, please, is it an annular sound or is it a valvular sound? Is it due to the annulus getting screwed, or is it? Yes, it's the annulus. Good. Annulus is like an opening, guys. That's it. So rheumatic fever and infective endocarditis can cause either mitral regurg or a tricuspid regurg. So make note now that any form of rheumatic fever and infective endocarditis acutely can lead to a regurgitation murmur. Chronically lead to a stenosis murmur. For stenosis to occur, it needs years. Stenosis is a process that takes years and years and years to occur. You need to get this calcification process, dystrophic calcification, which we spoke about the other day. To get dystrophic calcification, you need time, you need destructed tissue, and you need calcium. So for this to occur, it needs years. So initially, if you have like rheumatic fever or infective endocarditis, you will never get a stenosis. It's always a regurg. Okay, guys? Mitral regurg and tricuspid regurg. Okay. Let's take a look at the picture here. Here we have mitral regurgitation. In case of mitral regurgitation, it's a problem with the valve opening or closing. Mitral regurgitation is a problem with the valve closing. Excellent. Okay, so since it's a problem with the valve closing, if you cannot open, by the way, if you cannot open your Telegram and watch the screen at the same time, you can do as me. I'm putting my phone next to my laptop, so I'm reading your answers and looking at the screen at the same time. So if it is mitral insufficiency, there is more blood going inside of the left atrium. You remember which wave we said it represents the filling of the left atrium? Which wave? V wave. We said V for Willing. Yeah, it used to Willing. Yeah, Willing the. Yeah, exactly, Willing. Cool. So V wave. So the V wave, there is more filling because of the regurgitation. So look what happens. See? You have the V wave becoming much more prominent. Excellent job, guys. So you see why I took time on that the other day, because now it makes sense. Okay. On inspiration versus expiration. On inspiration, what will give more sound? Is it the mitral or the tricuspid? On inspiration. Good. So now let's go to the next one. Okay, guys, I have a tricky question. I hope you will answer it correctly. Aortic stenosis versus mitral regurgitation. Which one will have better sound on the hand grip? Only aortic stenosis, because I told you guys the if the maneuver changes the preload, it will affect all heart murmurs. But if it solely and only changes the afterload, it will only increase the regurgitation murmur. That's it. Good. So actually, the improvement of the aortic stenosis murmur is due to the improvement of the gradient between the left ventricle and the aorta. Yeah, you need to know this. Okay. Next one will be mitral valve prolapse. So for mitral valve prolapse, it has click my variable points. So mitral click, you have the click here. Okay, guys, you must know about the click. So it's a late systolic crescendo murmur. What does a crescendo mean? It only move up. It's like notice S1, nothing, a click, sound. It's kind of difficult to do. No. But the next click, the click itself, sometimes it can be a little bit hard to listen to. And thankfully, in the actual exam, they don't give it to you to listen to, you know. They give you the S3 in the exam, the S4, they give you the mitral regurg, they give you the tricuspid regurg, they give you all of these. But when they find like one murmur really tricky, that is really tricky to get, they don't give it to you. And if they are going to give you this one, they will show you this picture like this. They will not say mitral click on it. They will just show you this and write nothing on it. And you have to know that the click, the mid-systolic click, this one, it will be in systole, and it will be here, and the murmur after it will be a crescendo murmur, guys. Okay, so it's a late crescendo murmur, systolic crescendo murmur with a mid-systolic click due to sudden tensing of the chordae tendineae. Remember, guys, like there was parachuting, and after the parachuting, who tensed? It was the papillary muscle, which led to what? The tensing of the chordae tendineae. So contraction of the papillary muscle tensed the chordae tendineae. That pulled the parachuting valve from the left atrium back to its place. That did what? It created the sound. Which sound? Click. Click. Okay. So, yeah. As mitral valve prolapse into the left atrium, chorda cause a crescendo with a click. So the crescendo with the click, it's just the movement thing we spoke about after the tensing. It's the most common valvular lesion. Guys, take a guess. From 100,000 people, how many had it? Just a guess. Would be cool to see. More than 70. How much do you think? More than 250. How much do you think? More than 400. How much do you think? A lot. Good answer. Around 1,000 actually. 1 in 100 people have it. Okay? And most of the time it leads to no symptoms, no problem. It's benign, nothing wrong with the patient. But you need to keep its association with other problems. Keep in mind. So, they write, most frequent valvular lesion best heard over the apex because it's in the mitral valve, so it will be over the apex. It is loudest just before the S2. Really quick question to make sure that you get the point. Where is the apex is located? Is it right or left to the midclavicular line? Exactly, it's at the right. 2.5 centimeters to the right. Okay, so loudest just before the S2 and at the fifth intercostal space. Excellent. And it's usually benign. It can predispose to infective endocarditis. Guys, in case of infective endocarditis, it's infective, so it's due to bacteria. We'll speak about it deeply. But in general, I want you to know that the bacteria, when it sees damaged valve, it will be like, nom nom. Looks tasty. So it will feel like it's the trustworthy place for it. And it will go to it directly, attach to it, and start infecting the whole area. Okay? So, yeah, it needs a damaged tissue. And what a damaged tissue is better than a beautiful mitral valve that is prolapsed. Yep. So, someone wrote dextran, which is like one of these antigen that facilitate the adhesion to a destructive valve, especially in the Streptococcus viridans. And yeah, it goes to the scar tissue and just attached to it. We'll be explaining for you guys Streptococcus viridans when we reach it. And guys, I want some stuff. It can be also to aureus, and I will explain to you the difference between the two when we reach that topic, guys. Leave it for a little bit later. So now I just want you to know the following. It can predispose to infective endocarditis. It can be caused by myxomatous degeneration. I kept telling you today this word. It could be due to primary or secondary connective tissue diseases. Which connective tissue diseases? Marfan or Ehlers-Danlos Syndrome. Can someone please tell me Marfan gene dysfunction is located at which chromosome? It has an F in the word. Marfan. It's 15. F for 15. 15. So the next one, will be as follow. Ehlers-Danlos Syndrome, it's a defect in the collagen type. Was it type 5 collagen or type 3 collagen? Let's see people get it tricked. I love it when I see people get it tricked. Yeah, well, someone got it. Okay, type 3, correct. Why not type 5? Because the type 5 is mostly the musculoskeletal stuff, yeah? But type 3 is mostly the vascular stuff. Please keep in mind that in case of Ehlers-Danlos syndrome, ladies can also have one another syndrome. It's really difficult for them to become pregnant because their uterus basically rupture because it does not have enough normal collagen in it. Also, they write here, rheumatic fever, particularly in developing countries, can lead to mitral valve prolapse as well. And finally, cord rupture. What can lead to cord rupture? Other than MI, it could be actual surgeries or some infective endocarditis topics we will speak about later. And finally, I want you to know about VSD as a systolic heart sound. It's a holysystolic sound, okay? And it has, why holysystolic? It was one of the three that we said were holysystolic, mitral, tricuspid, and VSD. So holysystolic, it's a harsh sounding murmur. It's loudest at the tricuspid area, while the ASD was loudest at the pulmonic area. Larger VSD have lower intensity murmur than smaller VSD. When I tell this to my student, they get a little bit confused. How come big like the defect have a lower sound than a smaller defect? Look guys, if this is the VSD, imagine like from the left side to the right side, this is how big it is, okay? Like let's imagine that how big it is, and the fluid is moving through it, so it's like this. So now it's like this, okay guys, it's small. So this, it's like a hose, water hose. When you compress it, the sound is higher. When you dilate it, the sound is lower. So the bigger it is, the less turbulence, as you wrote, it is. Correct. So let's imagine. So you get it, guys? So the sound is like this. Make sense? The bigger the hole, the lower, loudest the sound. Does it make sense to everybody? Excellent. Good. Let's keep going. So, yeah, the bigger the hole, the lower the sound, because less turbulence. So actually, if they tell you a question, and I saw this question before actually, they tell you about someone, like he had this VSD, and then they tell you that the sound become more intense. Does that mean he's going to have better prognosis or worse prognosis, or is what happening exactly? Correct answer that it's a closing. It's a closing, guys. The VSD used to be so big, so it did not lead to anything. But now it's a closing, so it's becoming much more smaller, okay? And since it's becoming smaller, it's leading to the sound becoming more intense. Please know about this topic and the different size of the opening changes, leading to more and less sounds respectively. Because if you get this point, you will understand when we keep telling you about wheezing in the future. So now the next heart murmurs you must know is the diastolic ones. Well, which one are diastolic? I don't know. Let's go to take a look at the graph. So you just make a line, S1, S2. You tell yourself, okay, so here we have mitral stenosis here. So we have a tricuspid stenosis here. We have pulmonic and aortic here. So if these are stenosis, this will be regurgitation. Here we have again mitral. So here is stenosis, here regurg. Tricuspid, here is stenosis, here regurg. Pulmonic, here regurg, so here is stenosis. Aortic, here regurg, so here is stenosis. Okay, so in case of diastolic, we have an aortic regurgitation, which is a high-pitched blowing, early diastolic decrescendo murmur. That's a lot of words. So let's take it one point at a time. Decrescendo murmur, we get it. It goes down, okay? Early blowing, which means it directly starts when the S2 happens. Which valve close at the S2? Excellent, the aortic and the pulmonic. Since regurgitation is a problem of the aortic closing, it occurs exactly after it closes because it cannot close normally. So it occurs directly after it tries to close. So high-pitched blowing, early diastolic decretion de murmur, it's best heard at the base, aortic root dilatation, or the left sternal border if it was valvular disease. So in case of aortic root dilatation, it can be in which diseases I told you about today. I told you about two diseases that can lead to aortic root dilatation. It's not HOCM, no. Something that lead to dilatation of the aortic root itself after the valve. The first one was syphilis. I told you about how syphilis can lead to aortic dilatation, and the next one was an aneurysm, like an actual aneurysm of your I want to show you syphilis. Okay guys, take a look here. You can see in case of syphilis, look how big is this aneurysm that has formed inside of the aorta. This can lead to dilatation of the annulus. Yeah guys, so if you have dilatation of the annulus, the sound will be you will get what? Regurgitation of the aorta. See this guys? Oh, let me test you guys. Which chamber is this? What is this? Let me test you on this. Left ventricle, correct. So one was left ventricle. Which valve is this? It's the aortic valve. What about this one in yellow? This is the mitral valve, correct. What is this? The arch of the aorta. Why it's like this? Why it's big? Yeah, because it's dilated. An aneurysm. And what about this anterior most chamber of the heart here? What is it? This. Right ventricle. Cool. So guys, what about this posterior most chamber of the heart? What it is? Cool. See guys, you have mastered anatomy of the heart. You can take a look at a CT scan with contrast and just a piece of cake for you. Okay, so yeah, I'm proud of you guys. So here we have the following. If it was due to aortic dilatation, due to syphilis, that's one cause. The other cause is an actual aneurysm due to Marfan Syndrome, for example. These will lead to the murmur being heard at the second intercostal space at the right, which is the base of the heart. While if it was a valvular disease, it will be on the left. Okay? So, in case of syphilis, will it be affecting the annulus of the heart or it would be affecting the valve of the heart? Let's see if you understand or not. Annulus, yes, because it's the annulus, because it's lead to dilatation of the aorta. The valve is not touched, it's just the aorta having the aneurysm. So it becomes larger, so it stretches the annulus, make the annulus bigger, so it makes the valve fall. When the valve falls, that's regurgitation. That's it. Okay, so let's try this. Here they write, there will be long diastolic murmur, as you can see, hyperdynamic pulse, and head bobbing with severe will be when severe or chronic. Let me tell you a little bit about this, guys. What is the complaint of the patient? The first complaint of the patient will be, doctor, I feel head bobbing. I feel like my head is boiling. I can hear sound like of water falling like in my ears, like rivers moving in my ears. When you hear that voice, you're like, okay. What else do you have, sir? Well, you know, I have this hyperdynamic pulse. When I squeeze my nail, after squeezing the nails, when I left it, I start see pulsations under my nails. Let me show you this. Okay, so we have like the squinky sign, they call it sometimes. But for the USMLE, what I really like that they don't require from you to know all of these guys, you know? You don't have to know the names most of the time. But yeah, basically what will happen that under your nails, if you squeeze them and you let them go, you will take a look at the nails and you will see them pulsating. Open their mouth, the patient, look at the uvula, and when you look at the uvula, oh, beautiful country. And if you look at the uvula inside of the throat, it will be pulsating as well. If you look at the, what else? Yes, their head will be bobbing, uvula is pulsating, their nails are pulsating, dancing uvula, exactly. All of these are signs of aortic rigor. If someone really smart of you, he can remember what we said about the pulse pressure in case of aortic regurgitation. It's increased, exactly. It was one of this beta pneumonic signs, guys. It is increased. So there will be an increase in the pulse pressure in case of aortic regurgitation. So because blood goes back and then there is more blood in the left ventricle, it has to be pushed out and you have more pressure inside of the aorta. Yeah, so it goes ridiculously up. While during the diastole, the valve does not close. If it does not close, it will keep pulling back the blood backwards. See, it's not closing here. So the blood will keep going back to the left ventricle. So your diastolic blood pressure will go down. So this change in the pressures will lead to the pulse pressure being elevated. Okay, guys, so let's see the next point. Here they write, wide pulse pressure, causes include bicuspid aortic valve, endocarditis, and aortic root dilatation, rheumatic fever as well. It might progress to left ventricular hypertrophy. Guys, I have a question for you. What can lead to aortic root dilatation? I will keep annoying you with this until you get it, guys. What can lead to aortic root dilatation? An aneurysm. What else? Syphilis. That's it. Awesome. Okay. Endocarditis, it's bacterial endocarditis, love to affect damaged valve. Which valve is most commonly damaged in our body? Prosthetic, I mean, if you have normal valves, not prosthetic valves are always the most, yeah, mitral, good. Goes with the blood flow. Remember, it is mitral, second most common, aortic, third most common will be tricuspid. Okay. So then we have mitral stenosis. Mitral stenosis, it was the only one you had to memorize if you remember. It follows an opening snap. It's a snap, not a click. Okay? Snap for stenosis. A click for a click, my variable point. A tricuspid problems, as the person here wrote, it's in IV drug users. Why? Because they insert the Staph aureus to their veins, and when the blood full with the Staph aureus come back from the veins, the first valve that it meets inside of the heart will be the right heart, the tricuspid valve. Excellent. Okay, so the mitral stenosis follow an opening snap due to an abrupt halt in the leaflet motion in the diastole. So during the diastole, what happens? We have filling of the left ventricle from the left atrium. Good. So there should be opening of the valves. So you remember that stenosis is a problem in opening. So there will be an abrupt halt of the leaflet motion during the period that it normally should just open. So it's not opening as it should be. Yeah. So it's a problem in opening. After rapid opening due to the fusion of the leaflet tips. So what is happening exactly here? Guys, I'm taking this point and I'm just focusing on it a little bit more. Look here. So what is happening here exactly at the S2, normally, which valve is supposed to open? Someone write me. Normally. Mitral and the tricuspid. So what happens here, the mitral should open, okay? But it's not opening. Why? Because it's a steno, so it's shut down. Yeah? Until the pressure becomes really high and you have an opening snap. So it's like, here we have like the time when it's supposed to open, but it's still closed. But what happens here? That shooting was the opening snap, and you will hear it. So when you hear that opening snap, it means that it has overcome the stenosis and now it has just opened. And after that, the blood started flowing to the left ventricle. Okay, so this area between the S2 and the opening snap is just like the mitral valve is still shut because it's stenotic. So they write for us. There will be, due to abrupt halt in the leaflet motion in diastole, the opening snap is, after rapid opening due to fusion of the leaflet tips. There will be delayed rumbling mid to late diastolic murmur. And this is super important, guys. If you have this rumbling happening really early, okay, that's bad. Again, if you have this rumbling happening really early, it's bad. You must know this. It's correlated with worst prognosis. If they ask you what can lead to worst prognosis and they write opening snap being closer to the S2, the more early the opening snap, the worse the mitral stenosis. Correct, yes. So yeah, and delayed rumbling mid to late diastolic sound, murmur, decreased interval between the S1 and the opening snap, correlate with increased severity. Left atrium has more than the left ventricle pressure during the diastole. Hope all that makes sense. Left atrium more than the left ventricle pressure, that just like self-explanatory. It's often a late and highly specific because nothing else can lead to late diastolic murmur. Late diastolic murmur. Remember, in case of aortic regurgitation, it was super early. It can be as a sequelae of rheumatic fever. But guys, you tell me, mitral stenosis, will it occur like soon in rheumatic fever or too late in rheumatic fever? Exactly, too late. Why? Because it takes a lot of time for the calcification to happen and for the stenosis to occur. Okay, exactly, calcification. Which form of calcification is it? Is it dystrophic or metastatic? They ask this. Excellent job, everybody. Okay, chronic mitral stenosis can result in pulmonary congestion. Why? Because imagine this, guys. If you have the mitral stenosis is just occluded, the blood will be moving back to the lung. If the blood will be moving back to the lung, there will be pulmonary hypertension. If you have pulmonary hypertension, you will be able to hear crackles at the lung bases. Yeah. So also there will be the patient might have hypertension and left atrial dilatation. If you have left atrial dilatation, do you remember, guys, what I kept annoying you? Where is the left atrium located? Is it the anteriorly or posteriorly? Yeah, it's the posterior most chamber of the heart. So it can compress what? The esophagus, lead to Ortner syndrome. What else other than the esophagus? It leads to hoarseness. So what is that? Leading to hoarseness. Exactly, the recurrent laryngeal nerve. Was it left or right? Excellent, it was the left one. Which ligament used to be near it? Ligamentum Arteriosum, which was in childhood, not in childhood, in embryology, it used to be a BDA, ductus arteriosus. Yeah, excellent, guys. So they write here, when you have dilatation of your left atrium, you can get an AFib. Why? Where is the ectopic foci of AFib located? Ectopic foci are foci that creates the balls, basically. Exactly, guys. It's the pulmonary vein. It's near the pulmonary vein. You must know this. And they have a cool picture here, but this will be for the future, guys. Oh no, not. Oh yeah, here it is. See this guy? Oh yeah, can you see it here? It's near the pulmonary vein. You must know this. A flutter comes from here. Going to take a screenshot, send you on the group because it's a good one. So, okay, let's go back and explain the last thing before the break. We have here, yeah, sorry about this. you can see in the left atrium the pressure is super high. Yes, because of the stenosis of the valve. It's just like easy, it's not that big of a deal. But you can see here it's super high. Yeah, left atrium pressure should never go more than 20. Here it's almost 30. Sorry, it should not go more than 12, not 20. So here they write Patent ductus arteriosus. How do you close it, guys? What do you use to close it? To close it, not to keep it open. Ibuprofen, possible. NSAIDs, possible. Indomethacin is the best. Excellent. To keep it open, you use prostaglandins. Which type of prostaglandins, though? Is it G? Is it P? Is it E? It's E2. E1 and E2. Excellent job. Okay. So, continuous machine-like murmur. What does it mean, continuous? So, it happens during systole and diastole. It's best heard at the left infraclavicular area. It's directly under your left clavicle, guys. It's not at the second intercostal space. It's directly under the clavicle. Second intercostal space, that will be an ASD. Yeah? Atrial septal defect. So, it's different. It could be due to congenital rubella infection or prematurity. Okay, so why rubella? We'll speak about that in microbiology. Okay, so BDA, public displays of affection are continuously annoying. Bad mnemonics. Just know that BDA is continuous. Why it's continuous, actually, guys? Do you know the patent ductus arteriosus, which two structure it connects? The aorta and the pulmonary artery. Guys, is it during systole or during the diastole the pressure in the aorta is higher than the pulmonary trunk? Oh, I love this. All of you guys got it rigged. It's both systole and diastole. Look, guys, I have the rule of 5. I did not teach you yet, so you are allowed to make a mistake. So the rule of 5 goes something like this. If you take a look at this. This is a structure of the heart. This is the left atrium. Well, I will not write the name. I hope you know the names. I draw it so many times. You must know the names for them by now. Okay, so this is the pulmonary trunk and this is the aorta. A BDA in red is just a connection between these two. Yes? So, guys, rule of 5. Do not make this mistake. It's pretty simple. What is your right atrial pressure? Anybody knows? Come on, somebody write it. It's 5. Okay? So what about your right ventricle? What on what? No, right ventricle is much lower than that. Come on, what are you speaking about? 120/10. That's left ventricle. 8 is too much. Well, it's a range actually. Nope. Okay, you did not study it yet, so it's okay. It's the rule of 5. Okay, guys? The pressure inside of the right ventricle, it is 5/25. So how you are going to memorize this? 5 multiplied by 5 is 25. Okay? So what about the pulmonary trunk? I'm speaking about normal. So in the pulmonary trunk, you are still stuck with the 5 rule. So you say it's 5 divided by 5 plus 5. So you first multiply, then you add. So it becomes 5/10. Okay, guys? Inside of your aorta, what is the pressure? (120/80). Awesome. Okay, so is it higher during systole or diastole? In systole, it's 120, which is much higher than the 5. So 120 is much higher than the 5. So there will be movement of the blood in yellow during systole from 120 to the 5. What about the diastole? Here it's 80 and here it's 25. So it's 10, sorry. So it's 10. So also during diastole will be moving. Always there will be moving. Systole and diastole, both of them. Since it's both of them, will it lead to systolic murmur or diastolic murmur? Continuous murmur, both of them. Excellent, guys. That's why it's a continuous murmur, because the pressure is always higher in the aorta than the pulmonary trunk. You must know this. Please keep in mind this rule of 5. You must use it like and get comfortable with it. I just made like I put it upside down. I'm sorry. Like, of course, systole is always higher than the diastole. So 5 multiplied by 5 is 25 on 5. Then 5 plus 5 is 10. And the 25, you just take it from here with it there. Again, 5 by 5 is 25. Then 25 over what? 5 plus 5, which is 10. But if you have connection between these two, like this, from here to here, it will be just passive movement. Screenshot of this. Here you go. Okay, so now we need to get like a little bit of a break, and we'll be back in 10 minutes. Okay, guys, come back at 8:30. Okay, welcome back, guys. I have one question for you. I will make you listen to one sound and you will tell me which heart sound do you think it is. Okay? So, here we go. Again, if you did not hear.
Соня знайшла класну машинку в наявності.
Sorry, reclam. It's advertisement. Just a second. What do you think it is, guys? First of all, is it systolic or diastolic? Excellent, systolic. Is it the same or is it going up and down? I will give you the trick to know if it's up and down or it's same. But how do you tell that it's the same? When you listen to it, guys, there is this blowing sound versus an ejection sound. Ejection sound goes like this, while a blowing sound just goes like. So exactly, stop suddenly. Let's try this again. Good. So yeah, that was one. From now on, for the next maybe 3-4 weeks, every time I come from a break, I will make you listen to a different heart sound. No, this one actually a holosystolic murmur, but it was heard on the mitral area. So what do you think it is? Mitral regurgitation, exactly. So yeah, the sound can be a VSD if it was heard in a different area, but because it was heard in the mitral area, it's a mitral regurg. But okay, so from now on, guys, for the next 3-4 weeks, every single time, we will after the break make you hear one sound and you have to diagnose it. So I see a question, how do you know what is the first sound and what is the second sound? Okay, look, it's pretty easy. When you, actually it's not pretty easy, it takes a lot of getting used to, but the idea is like this. Notice that between the S1 and the S2, it's really small period, okay? So that is small period, it's like there is sound, small period, sound. And then there is long, really long halt, and that halt is like really long. I'm saying just maybe 75% of a second. That is considered really long. So in the beginning, it might be difficult for you to determine what is what, but wherever the sound starts and ends, just today at night, try to listen to a heart sound, normal one. Put your headphones and keep listening to it for a half an hour. It becomes a second nature to you to know the periods and to know the S1, the S2, and the pause after them and between them. And it becomes a second nature for you to know what is normal and abnormal. So please do this, guys. Today at night, I will send you one video with the normal heart sound. You can listen to it with your headphones, and it becomes a second nature for you because you know, a stethoscope you will use for the end of your life. You must master this technique. Okay, so let's go back here. Guys, we are done with heart sounds. I know that some of it might have been difficult, but these type of things I will be testing you on for the next 3 weeks. Every single day, every single break, I will bring you one different sound and ask you about it. I hope it's fine with you, because if it's not fine with you, I'll be asking anyway. So let's see. We have myocardial action potential. Myocardial action potential is super important. It helps you to understand what is depolarization is, repolarization is, where we have contraction, where we don't have contraction, all of these stuff. Actually, let's start with the types of cardiomyocyte inside of your heart. You have two types of cardiomyocyte inside of your heart. You have typical and atypical cardiomyocyte. So, typical and atypical cardiomyocyte. The first one, the typical one, I will ask you a few questions about it. First of all, I will tell you where it's located and then you tell me the rest. The typical ones are all over the heart, okay? It's all everywhere, all. But the atypical only is located at the AV node and the SA node. They are pacemaker cells. So, can you tell me please, which one of these two has automaticity? Is it typical or atypical? Automaticity. Automaticity is the ability to make an impulse by yourself without any help. Exactly, it's the atypical one. Which one of these two can contract? Excellent, it's the typical one. Which one make 99% of your heart muscles? Excellent. Which one can pass? Yeah, that's enough. Oh, which one can share electricity between the can share impulse between the cells next to each other? This is a tricky one. Yes, the typical one. It's the typical. Good. Okay, excellent job, guys. So now we have like the pacemaker cells and we have the normal cardiomyocyte, actual muscles. Oh, by the way, is heart muscle a striated muscle or not? It is a striated muscle. Excellent. Okay. So myocardial action potential. Here they give us two forms of potential. We have this one with a slope and this one without a slope. Slope, no slope. What is the difference between the two? When you have a slope, it means you have automaticity. When you do not have a slope, you do not have automaticity. Automaticity is the ability to create an electrical impulse without having one initially. So here we have myocardial action potential. It has phase 0, phase 1, 2, 3, and 4. At phase 0, what happens? First of all, I want you to imagine that you have this myocyte. It's one of the typical cardiac myocytes. It has an intracellular region and an extracellular region. We know that cells in our body are bags of potassium. They keep telling us about this. They have a lot of potassium inside of them. And sodium, actually, it's more outside of the cell. Yeah? So, the first thing to happen is at phase 1. At phase 1, we have this upstroke, really high upstroke, rapid upstroke, and depolarization. Why it occurs? Well, basically, a lot of sodium enters the cells, okay? It goes inside of the cell. If it enters the cells, it will convert it from being negative to becoming positive, yeah? Why it's negative, why it's positive, you are not required to know that. If some of you want to know that, you can speak with me afterward and we'll speak about the proteins and the amino acids inside and how the negative current is created, but it's irrelevant for you in medicine. For minus 85 millivolt in the initially, after the upstroke and entry of all of these sodium is positive, right guys? It has a positive current. So the inner portion of the cell will become more positive. That's why it reached the zero. So that was phase 1. It's a rapid upstroke and depolarization due to the voltage-gated sodium channel opening. Okay, so what happens next? After all of that sodium went inside of the cell, we have another new period that you must know. It's the period of initial repolarization. So we have an initial repolarization occurring, and it does something like this. So it has inactivation of the sodium channel. He's like, sodium channels, chill, stop. So it stops it from working, and then it leads to voltage-gated potassium channels to be open. Well, voltage-gated potassium channels. Since it's voltage-gated, it only opens when the voltage is really high, yeah? And the voltage-gated sodium channel opens. Why it opens? To release some of the potassium from inside of the cell to the outside of the cell. Why it does that? If you take one anion from inside of the cell and you bring it out, and that anion is positive, the electrical activity will go down, obviously. So initially, you put sodium in. That's led to the phase 0 and the upstroke. Then you release some potassium out. That lead to the downslope. So this is why we have the downslope. Two reasons. The first one, we had inactivation of the sodium channels. The second one, it was voltage-gated potassium channel that began to open, okay? And after this happened, what we call it, like this area, we call it initial repolarization. Repolarization is like relaxation / stoppage of the contraction. And depolarization is basically the contraction itself. So if you take a look here, guys, you can see at this area, there is like a plateau type of thing, yeah? So the phase 2 is actually the plateau, and it's due to calcium influx through a voltage-gated calcium channel that balances the potassium efflux. So there was constant efflux of the potassium because which started to happen at phase 1 to compensate for the sodium coming in. And the potassium starts deciding to go outside of the cells to compensate for that. So the calcium sense it and be like, well, not on my shift. So the calcium will be put inside of the cell. Guys, do you remember when we spoke about calcium-induced calcium release? Exactly. So calcium influx to the inside through the voltage-gated calcium channels will balance the potassium efflux. Calcium influx will trigger calcium release from the sarcoplasmatic reticulum, and that will lead to myocyte contraction. I want a really smart student to tell me what protein led to the insertion of the calcium inside of the sarcoplasmatic reticulum in the first place. What led to insertion of the calcium inside of the sarcoplasmatic reticulum? Awesome, man. Oh, whoever you are, I don't know who you are, but yes, it is phospholamine, which is like an AT base, and yeah, it's super important to know about this. Okay, good. So here we have calcium influx. It triggers calcium release from the sarcoplasmatic reticulum, and thus you have a contraction. So please be careful, guys. If they ask you when does the contraction happen, do not choose phase 0. I have so many students who keep choosing phase 0 and they get the question wrong. When does the contraction happen of the muscle? Awesome. It's phase 2 because when you release the calcium and you have calcium-induced calcium release leading to contraction. Good. So next step, okay, we done that. We have contraction, voila, perfecto. What's next? We need to go back to relaxation state. We cannot stay in contraction forever after. We need to relax the heart so he can fill again. How can we relax the cardiomyocyte? Well, there will be a period of rapid depolarization. If there is something rapid, should be something brief or initial, which we already spoke about. It was the phase 0. It was not successful. So there will be rapid repolarization. There will be a massive potassium efflux, like moving outside from the cell. How? By opening of the voltage-gated, slow-delayed rectifier channels. Guys, see these rectifier channels? Know them. Why? See these channels, the potassium channels here? They are totally different from the potassium channels here. This is just a normal potassium channels, but these, we call them the rectifier. These are different from each other. This is not the same as this, the type of channel I mean. So these are the rectifier and these are just potassium channels. Voltage-gated potassium channels, rectifier channel. These can pass a little bit of potassium. These pass a huge amount of potassium. Okay? So the rectifier channels, there will be a closure of the calcium channels. So if the calcium channels are not working, no contraction. Remember, calcium contract. Okay, so the phase 3 has occurred. Calcium channel has been closed. We opened potassium channels and we have movement from the, how do you call it? We have movement from the phase 3 to the phase 4. So what occurs at the phase 4? Phase 4, look what happened during the whole area here. We have a lot of potassium coming out, potassium coming out, potassium coming out. Some sodium came in, some calcium came in. So practically the cell electrolyte, the whole electrolyte status in it got messed up. Normally there must be potassium more inside, sodium more outside. So you need to go back to the baseline, yes? To go back to the baseline, you need the phase 4, which gives everything back to its place. So there will be resting potential. There will be high potassium permeability through the potassium channel, which will bring the potassium from where to where? Let's see, from in to out or out to in. In case of phase 4, you want to return everything back to normal. So should you move the potassium from in to out or out to in? Out to in, because you want to put potassium in its normal place, which is inside, not outside of the cell. Good. So you see during the contraction, there was a lot of potassium released outside. Now it's time to put all of it inside. To put all of it inside, you have activated the potassium channels. Okay, guys, all of this situation is happening in cardiomyocyte. Two places it does not occur, the SA node and the AV node. In these places, they are atypical cardiomyocyte, and that process will be at the base. It will be like pacemaker type of action potential. It's totally different. So in contrast to skeletal muscle, why they contrasted with the skeletal muscle? Because both of them are striated muscles. Yes, guys? And there is the following situation. So in contrast of skeletal muscles, cardiac muscle action potential has a plateau due to calcium influx and potassium efflux. So cardiac muscle action potential, it plateaus. This is the plateau. If I draw for you guys an action potential of a skeletal muscle, hope you remember how it looks like. It's just like this. That's it. So this is the sodium, this is the potassium going out, and this is the homeostasis, like potassium getting back in, and that's it. Nothing more complicated than this. But in the heart, it adds something. So there is calcium in the way. That's why we have a creation of a plateau before the potassium takes its place. And can someone tell me, when the massive amount of potassium go outside of the cell, was it from the potassium channel or the rectifier potassium channel? The rectifier, exactly. Good. So here we have, in contrast to skeletal muscle, cardiac muscle action potential has a plateau due to calcium influx and potassium efflux. So it's this phase. And cardiac muscle contraction require calcium influx from the extraplasmatic reticulum, which induces calcium-induced calcium release from the sarcoplasmatic reticulum. Calcium-induced calcium release, we keep speaking about it. And the calcium-induced calcium release is also active with utilization of which drug? I can see your conversation on my phone, so you can write. Calcium-induced calcium release can be induced by using which drug? digoxin, excellent job. Because digoxin inhibits the sodium-potassium channels, which lead to more what inside of the cell when it inhibits sodium-potassium channel? Initially, yes, calcium, but initially before the calcium, sodium. When the sodium becomes really high, that will lead to the blockage of the calcium-potassium exchanger, exactly, and that will lead to accumulation of the calcium, and that lead to calcium-induced contraction. Excellent job, guys. So, here they write, yeah, so that was the calcium-induced calcium release. So cardiac myocytes are electronically coupled with each other by gap junction. Guys, if you have to memorize something from this page, it will be the gap junction. They love it, they keep asking about it, and you guys must know it. The gap junction is just like little channels. I like to think about it like this, and it connects two cells to each other. So imagine this is one cell and this is one cell, and there is a gap junction between them. So these gap junction just pass ions from cell A to cell B. And if they pass ion from cell A to cell B, they can pass action potential between the cells. And if this is true, and they pass action potential between the cells, they can lead to propagation of the action potential inside of the cardiomyocyte from one cell initially to multiple cells eventually. Okay, good. So, what else I wanted to show you? Yeah, back here. Okay, so occurs at all cardiac myocytes except those of the SA node and the AV node. I hope that made sense. That was the myocardial action potential. It was not that bad. Yeah? Does anybody have any problem with it? Awesome. Good. So let's speak about the pacemaker cells a little bit. The pacemaker cells are not that difficult as well. If you know the myocardial action potential, the pacemaker is a piece of cake. So it occurs at the SA node and the AV node. And the key differences from ventricular action potential include, first of all, let's take a look at it down there. Where is phase 1 and phase 2? They do not exist. So we have a total absence of phase 1 and we have total absence of phase 2. Okay, guys? You must know you have no phase 1 and no phase 2. What happens during phase 1 and phase 2 in this one? So here we had like the initial repolarization and the plateau, but in case of pacemaker, you don't have this. Why you don't have this? Because no time for that. You need to keep it going, you know? So it occurs in the SA node and the AV node. The key differences from the ventricular action potential include the following. First of all, at phase 0, see phase 0, the upstroke occurs due to opening. Look here, it's calcium channel. In the first one, it was sodium channels. Calcium channels, sodium channels. Okay, so it's due to opening of the voltage-gated calcium channels. And fast voltage-gated channels, fast voltage-gated sodium channels are permanently inactivated because of a less negative resting potential in these cells. Okay, so why it's due to the calcium channels? Why it's not like its a friend, sodium channels? The previous cell, the normal myocyte, did it with sodium channels. It was cool, no problemo. But here in this new cell, it's only the calcium channels, and the sodium channels will be completely inactive. Why? Take a look here, guys. What is the level? It's minus 40. Yeah? Go here. What is the level? The lowest level, minus 85. So since the level in the atypical or the pacemaker cardiomyocyte is less negative, see guys, it's less negative, the sodium channels block themselves. They don't have to work. And instead, they bring calcium to do it. They are like, calcium can cut it alone, we don't have to deal with it. So, they're right, fast voltage gated sodium channels are permanently inactivated because of a less negative resting potential of these cells. So this is the resting potential. It's around like 40, and here it is like minus 85. So because it's less negative, you have only activation of the calcium channels and not the sodium channels. This results in a slow conduction velocity that is used by the AV node to prolong the transmission from the atria to the ventriculi. So there will be a slow conduction velocity that is occurring at the AV node, and that will be super important. Guys, forget about this whole text. Just imagine this with me. If you have a delay happening at the AV node, delaying the electrical activity from going from the atrium to the ventricle, why is this super important to have a delayed activity? Why AV node work as a basically a brake? It makes it like delayed. The ventricles contract much after the atria. Why do you think that's important, guys? Someone write. Why the AV node delays the contraction of the ventricle? Yes, you need time for filling. You need time for the ventricles to fill fully, and you need time for the atria to do their systole and fill the ventricles, correct? So yeah, that's one of the most important concepts to know here. So the results in a slow conduction velocity that is used by the AV node to prolong the transmission from the atria to the ventricles. Phase 1, phase 2 are absent. You don't need them because this is like a process that needs to keep going, and you need it to happen fast actually. The next phase is phase 3. So you jump from phase 0 to phase 3. If you remember phase 3, if it is in the first one or the second one, it's the same. It's repolarization. Repolarization is due to inactivation of calcium channels and increased activation of the potassium channels. So if there is inactivation of the calcium channels and increased activation of the potassium channels, calcium channels led to contraction, so no more contraction. And increased activation of the potassium channels, that led to repolarization. So repolarization start occurring. Okay, and also the patient will have they write here, the patient will have more potassium efflux outside. That will lead to what? That will lead to repolarization. So that was phase 3. What about phase 4? Well, phase 4, it's the thing that makes the automaticity of the cell. So if they actually make a note about this, phase 4 makes the automaticity of the like the SA node and the AV node. It's a slow spontaneous diastolic depolarization due to the funny current. Okay, what is the funny current? It's not that funny. Well, I'm kidding. It's the funny current. They also call it the leaky channels. Maybe you would like to write that name down. Leaky channels. So it's the funny current. It always leaks a little bit of sodium and a little bit of potassium. And when it keeps leaking, eventually it will reach the threshold. And when it reaches the threshold, you will have what? Full depolarization, which is due to calcium. Yeah. So you can imagine what is happening right now. There is movement of some sodium and potassium to the inside of the cell slowly until they reach the threshold, and then a lot of calcium is entering the cell, leading to contraction, and after that we have repolarization with the potassium going out, and yeah, that's pretty much it. So they write slow spontaneous diastolic depolarization due to what? The funny current. The funny current channels are responsible for a slow sodium potassium inward current. So different from the phase 1 current that was here. See this one, guys? It's not the same. These are actual sodium channels, but these sodium channels in phase 4 in this atypical cardiomyocyte, they are the leaky channels. That's why I don't use the word funny channel. I don't use the word like this one, the funny current. It get me confused. Every single time I see like a sodium channel, I start asking myself, is it the one for the typical or the atypical cardiomyocyte? I get confused. So I just told myself, okay, the normal sodium channels are located in the typical cardiomyocyte, while the leaky channels are located in the atypical cardiomyocyte. So yeah, that makes it much more simple. Okay, so we keep going. They write, here they write, it accounts for the automaticity of the SA and the AV node. The slope of the phase 4 in the SA node determines the heart rate. What does that mean? See this slope? If I can see the chat, so you can answer there. If I make the angle of this like this, like this. Will the heart rate be more or less? Exactly, faster heart rate, because it will be happening like this. Yeah, it will be much faster. Okay, if I decrease the slope comes like this. What happens? Excellent, bradycardia. No problem. Okay. So, guys, take a look. I have this funny cat kiss. I know it's stupid, but it helped me to memorize that it's funny for what? The funny is for the funny current, the first one. Cat is for calcium, and kiss is for potassium. The one who wrote about ivabradine, you are completely correct. It works on the funny channels. I will speak about it when we reach it. Okay. Now let's take just 5 minutes break and come back after the break. We'll finish echocardiography. See you guys at 9:05. Guys, some people are writing me in private that they must go and stuff like that. So I will open a poll for you guys. If you wanna leave, you can write that yes, we want the class to finish. If not, write not, and according to the poll, we will do. Anyway, for the people who have to go, the lecture will be uploaded on YouTube. Okay, guys, so according to the Telegram, most people want us to continue, and a lot of people suggested that we continue with amyloidosis, which I think it's a really good idea actually. Since the next topic, like if you keep telling someone cardiology, 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 he will become crazy. I know it. And we just, yes, it's only 3 pages we explained today in 3 hours, but still, it's hard topics. I get it. Like, the heart maneuvers alone is one of the most hardest topic in the whole like book. So yeah, I get it. So tomorrow we'll be speaking about electrocardiography and speaking all of the heart rhythms and finishing up cardiology. But for now, let's speak about amyloidosis. Amyloidosis is a process that occurs in our body. It's pathological. It's not normal. Why we must know about it? Because here's the idea, guys. Amyloidosis is just, what is amyloid? It's a protein. It's a misfolded protein. That's the idea. So it's an abnormal aggregation of proteins or their fragments into the beta-plated linear sheath. You must know the beta-plated linear sheath. It's just like a chemical structure, guys. And these fibrils are insoluble. They do not dissolve in water. And they can lead to cellular damage and apoptosis. Apoptosis was controlled cell death. So you must know that amyloidosis can be stained. There is 2 stains you have to know about. The first one is the Congo red stain. And in the Congo red stain, it stains, you guessed it, it's red. So it will be red-orange and just like seen like this. If you must know what is the most common organ to be involved with amyloidosis. It is the kidney, guys. So the kidney is the most common organ involved with amyloidosis. Why? Because it's the organ that clears all of your amino acid and then reabsorb them. But in case of amyloidosis, it will clear them, and when it reabsorbs them, the amyloid will accumulate inside of the kidney. So they write here the following. Also, apple-green birefringence can lead to what? Can be seen an apple-green birefringence, but this is polarized light. So the first one was just like was simple light microscopy, but the second one was polarized light. It's something like a technique that we use, an actual technique, and you see it like a greenish, but the green that is for apple. Okay, we call it apple-green birefringence. And these 2 pictures are for amyloidosis. This is Congo red, this is apple-green birefringence. Okay, so here they say an H&E stain, they show deposition in the glomerular mesangial area, and tubular basement membrane are enlarged on light microscopy. So the tubular basement membrane will be enlarged on light microscopy. Okay, all of this is important, but what is really important is these guys. Guys, I want you just to think about amyloidosis as follow. There are so many causes, and there is like many diseases. But in general, there is systemic disease and localized disease. Localized disease are only within one set of organ, and that's it. They don't affect all over the body. But systemic disease, they can affect multiple organs at the same time. It's systemic. It affects all of the organs. And the last one is hereditary. Let's start speaking about the systemic ones, which is the most important between all of these. So the first one is primary amyloidosis. We have secondary amyloidosis, and we have the dialysis related one. So the primary amyloidosis is due to plasma cell dyscrasia. Plasma cell dyscrasia means multiple myeloma diseases. So what is the idea here? In case of multiple myeloma, what is the problem? We have a lot of plasma cells. What does the plasma cells make? Immunoglobulins. Immunoglobulins, which type of chain do they have? Heavy chain or light chain? They have both. But for amyloidosis, we only care about the light chain. We don't care about the heavy chain. So this light chain can create an amyloid called AL amyloid, the L for light chain. So this AL amyloid will keep going all over your body and accumulating in organs. It can accumulate in your heart, GI, renal, hematological, and in your spleen. It can in the brain and in the muscle. But the most important organ is what? Correct, it's the kidney. The kidney is most important organ that can have what? Amyloidosis. Okay, so it can be a complication of multiple myeloma. Good. Because of light chain deposition inside of the kidney, leading to this misfolded beta-bladed protein being accumulated inside of the kidney, leading to nephrotic syndrome and kidney damage. Yes? So the nephrotic syndrome, what is the definition of nephrotic syndrome? It's when there is a lot of protein going inside of the urine. In this case, which protein is it? It's the light chain, which comes from what? The plasma cells. Yeah? The plasma cells are what? Plasma cells are some form of beta cells that become mature. So a beta cell can be like naive and stupid, and then it understands life. So this guy is like, hey, naive. And then he becomes like not naive anymore. Yeah? So that's a plasma cell. He knows what he's doing exactly. So, yeah, the secondary amyloidosis goes something like this. It's a due and secondary. When I tell you something is secondary, so there is something else that creates the amyloid. Yeah? What is this something else that leads to creation of the amyloid? This something else is inflammatory states. So, can someone write me any inflammatory state you know, guys? It doesn't matter. Just tell me about a chronic inflammatory disease. One chronic inflammatory disease. Rheumatoid arthritis, excellent. SLE, bravo. Familial Mediterranean fever, good. Crohn's, excellent. Ulcerative colitis, good. MS, not bad. But MS is a little bit off, but okay. So the next one, it goes something like this. So we have the systemic finding include something like that. The secondary amyloidosis, you said it's seen in chronic inflammatory condition like rheumatoid arthritis, inflammatory bowel disease, which include ulcerative colitis, and the Crohn's disease comes under IBD, and familial Mediterranean fever, and the protracted infection. Okay, guys, I have a question for you. In case of serum amyloid A, and it leads to formation of serum amyloid A, which lead to secondary amyloidosis, which can affect all of these organs again. But my question, have you ever heard of a disease called osteoarthritis? It ends with itis, osteoarthritis. Can it lead to amyloidosis or not? Some people say yes, some people say no. More people say no. Well, osteoarthritis, yes, correct. It's written, it ends with itis, but it can never lead to amyloidosis. Why? It never can lead to amyloidosis because it's not an inflammatory state. So you'd be like, yeah, don't be stupid. It ends with itis, so it must be inflammatory. Well, it was misnamed. It was a mistake, and it was misnamed, but they kept using it for 100 years, so they were like, oh shit, we cannot change it now. So they kept using it, osteoarthritis. It's a degenerative disease, not osteoarthritis, not arthrosis. Well, yeah, that's more correct to say it, but it's osteoarthritis. When you write it, it's osteoarthritis, but it's not an inflammatory state. Be careful, guys. It's just a what? A degenerative state. You must know this. So it cannot lead to what? It cannot lead to amyloidosis. Okay? That's it. Good. So let's go back here. They keep giving, why I'm telling you about this? Because they will give you a list that has many diseases that can lead to secondary amyloidosis, and you will find there rheumatoid fever, and you will find osteoarthritis. You will become confused between the two. And you can just, when you see osteoarthritis from now on, it's degenerative disease, just remove it. It's not the correct answer. The last one is dialysis-related amyloidosis. It's seen in patients with end-stage renal disease and on long-term dialysis. It's due to accumulation of the Beta2 Microglobulin. Okay, so what is this Beta2 Microglobulin? Guys, if you've done immunology yet, we are going to do it in the future. I'm going to remind you about this. It is Just a second. Well, it's just like located inside of the immunoglobulins. There is something called, oh, here it is. Yep. Can you see the microglobulin here, guys? This microglobulin in this area, in patients who do dialysis constantly, they will get what? Microglobulin, protein basically, accumulating inside of all over their body because it's a systemic form of the amyloidosis. Okay, so which organ it can affect and which manifestation it has? All of the primary, secondary dialysis related amyloidosis all lead to the same thing. They can have cardiac problem, restrictive cardiomyopathy. It's an infiltration of the cardiac muscle itself. It's not hypertrophy of the muscle, it's infiltrative. It's a foreign material accumulating inside of the heart. While in the GI, it can lead to big ton macroglossia. The ton is really big. Which triosome has a really big ton? Come on, someone write it. Quick, quick, quick. Down syndrome, awesome. What about and hepatomegaly can be also a consequence of amyloidosis. So the renal, Noan syndrome also has big ton. Good. So renal syndrome, renal problem due to amyloidosis can be nephrotic syndrome, in which in nephrotic syndrome we have more proteins going inside of the urine, more than 3 grams per day. And hematological problem can be easy bruising and splenomegaly. Neurological problem can be neuropathy. Please make a note about how they can lead to pulses of different nerves, okay? And also they can lead to musculoskeletal problem like carpal tunnel syndrome, which affect which nerve? Someone write the name of the nerve. Median nerve, excellent job. Okay, so the localized amyloidosis, it affects only one system or one organ, like in Alzheimer's disease. It's due to beta amyloid protein, which is cleaved from the amyloid precursor